the jeopardy of what we're all facing now because of the federal changes and the impact they're now having down at the state level, it's requiring all of us to be more engaged.
Welcome to Rural Health Today. I'm J.J. Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. I'd like to give a warm introduction to today's special guest, and we had a chance to meet not too long ago. We'll talk about those circumstances in just a minute. But Dominick Pallone, it's so great to have you in the studio today. And, when I first met you, I'm like, I got to get this guy in the studio. You brought such a great depth to our conversation with healthcare leaders and payers alike not too long ago in Detroit. And we'll talk about that in a minute. But Executive Director at the Michigan Association of Health Plans. Now, I didn't know much about this because I thought, what in the world is that? I mean, can you explain that? And you did a great job that day for me. And I was intrigued by it. I did not realize that this had existed. I apologize. Into what capacity that, you really work on behalf of the customer and those types of things. But we'll talk about that in just a minute. But first of all, why don't we talk about you and the organization? Let's talk with you first. So background, a little bit about yourself, how long you've been doing this, and then let's transition into what you do at the organization. And what is the organization?
Yeah. Well, JJ, first, thank you for inviting me to be a part of this. Yeah. And I definitely, like you, I enjoyed our time together at that Cranes event.
Yes, it's fun.
Speaking amongst colleagues about affordability and our collective leadership roles in trying to improve the system and trying to find more affordability. So when you said, hey, I have this podcast and I'd love you to be part of it. You didn't shy away. I was
happy about it.
I was, very willing to do it.
Well, thank you for doing it.
I appreciate the opportunity today to follow up on that. And a little bit about me and our association. So I'm a transplant to Michigan. I've been here since early 2000s when I came to Michigan State University originally, but I'm from upstate New York, from Syracuse, New York.
So you upstate New York.
Yeah.
You look at this institution in Lansing and say, I want to go there.
And I was like, they have far better weather in the winter
than
Syracuse does. So I want to go there. But great political science school, and in particular, the James Madison College.
Oh, very good.
So that's what attracted me to Michigan State. And
so major poli-sci?
I was international relations. So as a lot of us with IR degrees that are around the Lansing area like to joke, we kind of went to school to learn about warring nations.
Yeah.
And we landed in Lansing and found out
warring nations are right
there.
Warring cities.
Exactly.
Well, I'm a major was political economy at Hillsdale College, so absolutely loved that.
Yeah.
And you soon realize that you don't have to look too global to find some of the challenges that we face in our rural communities. And Lansing obviously has been quite active lately. We're going to talk about that in a minute. So you find yourself then, you're in Lansing, you're getting through school, you love that, you're graduating, you decide, I want to stay in Michigan?
I did an internship at the time. I was just trying to finish up my degree and needed an internship somewhere and was thinking D.C., maybe contemplating going into Foreign Service Office, taking the Foreign Service Officer exam.
Yeah.
And just sort of walked backwards into an internship at the state capitol at that time for a state senator who had served 26 years. She was
before
at the end of term limits. And she was the chair of the Senate Appropriations Committee.
Wow.
Shirley Johnson was her name.
Johnson.
She passed away a few years ago, unfortunately.
Yeah.
But great.
Quite a driving force she was.
She was amazing.
Powerhouse
to work
up
with.
on the Ways and Means,
Yep. And so got to learn under her and then some great staff. And when I finished my internship, she offered me a full-time job. And it was every college grad's dream to take something that they enjoy doing and get an offer coming right out of school. So
what was the position?
It was just a front desk position
in the
Senate Appropriations Chair office.
Right?
I was excited. I got to literally open mail and respond to constituents, answer phone calls.
Yeah. Did you love it?
I loved it. I moved up through the ranks and eventually served as committee clerk, where I got to learn a lot of the ins and outs of the appropriations process at the state level.
Yeah.
Got to work very heavily.
It's pretty remarkable.
Yeah, it's an amazing process, and glad to be a part of it from the inside, learning about it from a good senator with a lot of experience on appropriations, and then eventually, she was term limited out. I went to go work for a House member at the time as the chief of staff, Marty Nolenberg. From Oakland County. Both were from representing Oakland County.
Sure.
And enjoyed my time with Marty. That was brief. Went from there to a job opportunity to become a partner at a what we call a multi-client lobby
Oh,
firm,
sure, yeah.
just meaning we represent
Yeah.
many clients in
Yeah.
Lansing. And
Is that still in operation today?
they are, yeah. Midwest Strategy Group
Midwest
is
Strategy
the
Group,
name.
yeah,
Yep.
yeah.
So
Yeah.
was an opportunity there to be a partner with two others at the
Yeah.
time, and they've since grown
They have.
much bigger than my time there. But worked with them and was there about 7 years, and then this opportunity at the Michigan Association of Health Plans, or MAHP,
Yeah.
opened up.
Was it this chief executive position?
It was a transition period.
Okay.
So my predecessor, Rick Murdoch, who had been there for a good decade prior to,
Sure.
to my arrival, Rick was getting ready to retire. The board, I think in its wisdom, wanted a succession plan. And I represented MAHP at the time, and Rick
so
reached
he's
out.
familiar
and,
with you.
and suggested that I consider it. And after some good consideration with my
Yeah.
family, my wife, and my kids, decided it'd be a good fit. I enjoyed doing healthcare policy, and
Right.
there's more than enough change going
There's
on
more
in
than enough
healthcare to keep
change,
us
yeah.
busy.
So, Dominick, what year was that? Did you take over as director?
Oh, that was 12 years ago. So
12 years.
yeah,
Congratulations.
yeah.
Maybe the longest serving
It's gone
director,
fast.
huh?
Yeah, I'm getting close to
Getting
longest
close, are ya?
serving for the association. We have a good history with our association.
Yeah.
We date back to the 1980s. It originated as an association for HMOs. It was the time that
Oh, yeah.
the
Everybody's
HMO
joining
model was
HMOs.
new, and state was going through changes to its insurance code to recognize HMOs as entities and to regulate them.
Yeah.
And then solvency concerns and things of that nature evolved. And so our association's really only had 3 leaders in its overall time
That's
since
amazing.
going back to the 80s. So
That's amazing.
I'm happy to say I'm the third.
Good for you. And so is it board driven? I mean,
It
and
is.
how are the board members selected?
Yep. Yeah. So our board is made up of health plans that have covered lives and are geographically located in the state of Michigan.
Okay.
So we have 9 board members today. Everybody except for one big insurer, Blue Cross Blue Shield, is not a member of our association currently. But really every other major payer in our state, and usually it's the CEO. Sometimes it's like a VP or
Right.
a COO, but almost always it's the CEO
Yeah.
for the Medicaid plan.
Sure.
Seems to be the natural fit for us. So our 9 members, cover just under 4 million lives today.
Wow.
Most of them are in Medicaid. Most of their lines of business are in Medicaid. But
So what do you do for them? I mean, so what is the day-to-day function?
yeah, so our charge from the board is to try to lead in Lansing on promotion and advocacy of trying to drive affordable, accessible, equitable, high-quality health care and health insurance in our state, in
All right.
Michigan.
So really you have quite a few folks at the table that sometimes can have competing interest, right?
We do.
That's
yeah.
probably hard.
Yep, we start every meeting reminding everybody of the antitrust statement, as every good association should,
Yes.
and then we usually talk about how we're all partners here,
Right.
though, to try to get
We're
better
not
outcomes
enemies,
for our
we're not
members.
fighting for each other.
Yep.
Yeah, same relationship we have at MHA, right? We're all competitors at some level, but we all come together for the common good, which is to advocate for hospitals, whether rural or urban. So you've been doing that. Life's good.
Yeah.
And, we had this little thing called the One Big Beautiful Bill that impacted the state. We're going to talk about some of those things in a minute. Before we do that, and talk really more about some meat and potatoes of the issues that you deal with every day, to humanize you for our listeners. We have listeners across the world. Just downloaded some of our audience, and it's incredible to see. So to humanize you to them, tell us a fun fact about yourself.
So I'll give you 2 fun facts
Good.
quick.
Absolutely.
One, I was a college baseball player, not very good, obviously, because I'm here in this seat and not playing for the Tigers or the Cubs. It's
Well,
my
it's
favorite
Cubs.
team.
Just say the
yeah,
Cubs.
the Cubs are my favorite.
Well, I guess Tigers you can say are good now,
Sure.
but
Right, but so that's a fun fact. I still play a little bit of baseball.
Nice.
There's a league in Lansing
Good.
that I still stay a part of when I get some free time.
And you didn't coach. You didn't coach the leagues or do anything?
No,
really?
no, I'm not a very good coach.
Okay,
I'm a
all
much
right,
better
all right.
player
Much
than
better
I am a
player.
coach. Yeah, and then although I am helping out with one of my sons now as he's
Well, that's
getting a little
nice.
older. And then the other fun fact that's a little off the wall, but I enjoy talking about it. I'm colorblind. So
Is that right?
Yeah. So I'm fortunate enough. My wife helped me color coordinate today.
It's a beautiful purple.
Thank you.
See, because I
It's
am
purple,
too.
is it?
I am
All
too.
right.
I am. I'm colorblind. So
Yeah,
see,
so
we share some
There
similarities.
we go. There's
Yeah.
not too many of us
Yeah,
around,
there
but
isn't.
apparently a lot in healthcare.
Yeah,
So-
there is. There is. See, well, that's great. So 2 interesting facts. So, it's important for some of the topics we're going to talk about today. One of the things that I want to stress before we get into the meat and potatoes here, Lansing's changed. You were there decades ago. I've been there for a long time in different capacities advocating, but the whole climate in this country has changed. And, I think we still can say that we can find some commonality in our discussions, but that's pretty hard to find right now, isn't it?
It does. Yeah. I say this, we talk about this a lot in Lansing, and you're absolutely correct. I mean, my time there dates back over 20 years.
Yeah, decades.
Going back to staff. And a lot has changed in Lansing and not for the best, right? And we find ourselves more and more, no matter what the issue is, trying folks in Lansing, unfortunately, too often try to find political wins rather than policy wins.
They do, absolutely.
And I'm a big believer that good policy makes good politics.
Good policy, yeah, absolutely.
And that has gotten a little lost at times.
It sure has. Well, I'm excited to talk today. For our listeners today, health plans are an essential component to healthcare affordability and accessibility in the United States, but the cost of premiums, as we know, continue to climb. Dominick is here to provide insight in healthcare affordability right here in the state of Michigan. We'll talk about upcoming legislation, payer-hospital negotiations, those are always fun, and of course, what all this has to do with rural health. So let's start with just some general questions. When we talk about the role that you play as the director in relationship with the association itself as a greater body, with all the competing interests around the table, let me just ask this. What kind of legislative action does your association advocate for, and how have you been preparing for the implementation of some very dangerous, in my opinion, and concerning approaching legislation regarding healthcare plans, healthcare in general, whether it's our behavioral health plans, whether it's Medicaid reduction, a lot of things on the table right now, Dominick, that are just absolutely crushing hospitals. Let's talk about that in context of how you balance all of that within the legislature.
Yeah. Well, I appreciate that question. To kind of tee things off here, a lot of our advocacy these days in Lansing is focused around Medicaid.
Yeah.
As you alluded to, right, with the OB3, I'll call it OB3 or HR1 being enacted at the federal level, we are already starting to see those effects here in Lansing. I know rural hospitals are feeling those effects.
Yep.
Payers are feeling those effects within the Medicaid program. And we have more on the horizon that's going to get worse, unfortunately. We are very concerned, and we have this talk every day in Lansing with lawmakers about what the downstream tangible effects will be to people, whether it's in rural communities or in urban communities. We expect in Michigan to lose about 200,000 people off of the Medicaid coverage. That'll be over time. It won't be immediate, but it will be fast.
Absolutely.
And we will start to see that really, we'll send notices will start to go out at the end of this calendar year. Those first tranche of disenrollments, unfortunately, are likely to occur around March of next year.
They are, yeah.
And that's when you will start to see, and we will all start to see some sizable changes. From a payer perspective, what that means is the remaining population is likely sicker.
There.
Which means we call it acuity, or relative risk of that population is going to increase. For state and for taxpayers, that means the per person cost of Medicaid will go up.
It's going to go up.
Exactly. And so we're having that discussion right now with appropriations legislators as they're working even today on moving budget bills in Lansing, just kind of letting them know that the initial numbers that are being discussed in the budget negotiations, and it's early in the process.
It is.
That those numbers are too low, that there needs to be additional recognition and actuarial engagement, like get the actuaries, get the facts into this rather than just the politicization of OB3 or HR1. Right. And let's talk about what the facts will lead to a per member per month cost for Medicaid, and it's going to go up. We know that.
It is.
You can't argue with math on this. And then the downstream effects on providers, right? And you know this better than I do. If you have less members with coverage, those other people that lost coverage, they're not suddenly healthy.
No, they're not.
They're not suddenly, not seeing or needing services. They're still going to show up at your ER. They're still going to show up at your outpatient, your inpatient.
That's right.
Now that becomes more uncompensated care.
It does.
And I don't know, I worry about how rural providers can keep up with that.
Well, they're not going to. We're already hearing across the state of hospitals. First of all, we know the national statistics are 734 hospitals are at risk of closing. Half of those are at immediate risk of closing. 20 of those are identified in the state of Michigan. Very concerning because we're already seeing the divestiture of a lot of programs in hospitals that are smaller, getting rid of essential programs, whether it's obstetrics, inpatient psych services, you name it, they have to scale that back. I'd be remiss if I didn't ask this question while I've got you in the room. As you're having those conversations about Medicaid, it's heavy on everybody's mind right now. Seems to be a little bit of shift in Lansing right now over the last couple of weeks about maybe preserving, protecting, or enhancing Medicaid. So it might not be a total abandonment under the one big beautiful bill, which we'll get to in a minute. But what encouraging news can you provide us? Is there some headway, do you feel, being made?
I'm hopeful. I try to remain optimistic, right? If you don't in this job, especially in the Lansing advocacy world, you get grind down pretty quick. So I try to remain optimistic. I think across political lines, it does not seem to matter right now, and I think this is a very positive thing.
Yeah,
Republicans, Democrats, they do want to protect and preserve Medicaid. I think those two terms that you mentioned are kind of a growing buzzword right now in a good way for all of us. It's incumbent upon all of us, though, to educate those lawmakers as to what exactly that means.
It is.
They know they're hearing from their constituents that Medicaid is important to their communities. It's important to them personally, right? The growing numbers of folks that are being served by the Medicaid program, especially the expansion population now, it touches everybody in all communities across Michigan. And I think lawmakers are well aware of that now. And they're also well aware of the need that they don't want to just indiscriminately destroy the program or make indiscriminate cuts to the program. But they are struggling. I do give lawmakers and appropriators a little bit of credit.
They've got more than just healthcare to worry about.
They've got more than healthcare, right? And so we've had some major investments in roads in recent years.
Infrastructure.
I for one, would like to see additional major investments in healthcare and especially the Medicaid program. So a lot of our advocacy these days as we're talking with lawmakers is encouraging them that if they want to protect Medicaid, we want to protect Medicaid with them. We have plenty of ideas on how to do that. Yeah. We should get folks together, hospitals, plans, other providers together and talk about the best ways to protect Medicaid.
Agreed.
And I, for one, believe one of the key fundamental ways to do that is to segregate state resources for the Medicaid program. We have a Medicaid trust fund in our state. That trust fund has historically been rated for years. This is not something new. This goes back decades.
Yeah.
And you do see a lot of that trust fund being used for its original intended purpose. But it goes to everything like school scholarships and other programs that are out there.
Just
I would rather it stay in Medicaid, and I would rather the state start to have conversations about what other dedicated revenue today can they designate for that Medicaid trust fund so that it can preserve and protect Medicaid into the future.
Yeah, and we all know that the concern about increased taxes does not bode well with the community. So what existing tax credits, liabilities, whatever you look at, can be deployed in such a time as this, because we do have to remember as healthcare officials that it's just more than just us in the state budget. You have education, you have infrastructure and roads. So great point. I guess a follow-up question to you is, are we going to have a budget soon? Do you think we're going to go right up to October again like we normally do?
I checked my magic 8-ball before I got here. It said reply hazy, try again later. But no, the budget is moving right now. As
do you
we
think
speak, it is. Yes.
Okay.
There's
at a faster pace and cadence than last year?
It is than last year, yeah. Although last year's cadence and pace was bad.
It was bad.
So, yes. Yeah.
It was bad. Gridlock on both sides.
Yes. Yep.
So you think you see a little of encouragement there?
I do, yeah. In my time in Lansing, I was a part of a quote-unquote state government shutdown that lasted a few hours a bunch of years ago. This recent cycle was right up to that line, right? A continuation budget being passed for a few days.
At 3 a.m.
And then another,
Representative
when all
Wirtz
the best decisions
are made,
right? At 3 a.m.
Yeah, she's at 3 a.m. Texting me, and I'm like, well, that's a lot of work early in the morning.
Yes. Yep. Yeah. So I'm hopeful.
You're hopeful we'll have it?
Yeah, I think there's a good emphasis this year, House and Senate, to try to get the work done that needs to be done, a good commitment from folks. And I think they heard from their communities when they waited until October last year to pass.
Do you think advocacy is higher and engagement is higher among groups and people this year than you've seen before? Or how would you characterize that?
Yeah, I think at least in the healthcare world, it is higher. I think the jeopardy of what we're all facing now because of the federal changes and the impact they're now having down at the state level, it's requiring all of us to be more engaged. It's not just, our colleagues at the Hospital Association are out active. We see them day in,
Very
day
much
out.
so.
And so it's not just the usual suspects either.
No, it isn't.
I think we're seeing more and
Yeah.
more groups come to Lansing, and for good reason, to
Yeah.
tell their story,
Right.
communicate with their lawmakers and others, and to educate them as to what the actual tangible effects
Yeah.
of these things are.
Well, because there's so many nuances to healthcare, right? It's not just about Medicaid, but it's 340B. It's what are we going to do with provider tax? It's looking at nurse staffing ratios. It's about all of those things. It's not just about one issue. It's so complex today, and you've got your finger on the pulse. Brian Peters at MHA does a phenomenal job at the work he does, but then his team, Laura and the team, are incredible as well.
Yes.
All right, let's make a shift to something not popular.
Sure.
Okay, healthcare premiums. They're on the rise. You have a lot of people that didn't get the tax credit extension and therefore either are not seeking health care anymore, can't afford it, or, they're looking at some pretty heavy plans with high premiums and high deductibles. Let's talk a little bit about what's driving this. So let's talk about premiums in general. And, I guess what factors are most significant if you were to look at that equation of healthcare premiums? What's contributing to this rise right now? Because we often hear, on the other side of the aisle, as you argue against health plans, is they're making all this money.
Right.
They got all this money. During COVID, they made billions of dollars. Well, I don't think COVID can be our, case study here.
No, and I'm the first to say during COVID, we've refunded money, right?
Like,
right. We
Probably
do
first time ever.
Well, not first time
Okay,
ever, but
right.
but at a large scale, and I'll use the Medicaid program in Michigan. Medicaid plans in Michigan gave back more than $800 million to the state of Michigan during COVID, and rightfully so. We should, right? And that is the program requirements working the way they were intended. They're not intended for health insurance companies to make profits, make massive profits off, certainly not off of Medicaid, and really not off of commercial insurance.
But there is
either.
a reason you gave it back, though, Dominick. It was because people weren't using health care.
They weren't. Right. They were deferring
times were
healthcare.
changed. They were deferring it. We were being told, even at the government level, don't use your hospitals.
Right.
We were told surgery centers were shut down.
Yes.
ORs were shut down.
Yep.
So kind of did a little bit of that to ourselves. And then it looks like, the insurance plans are doing well that year. But then over time, people get back to work, right?
Yeah. They come back. And I'll say one step further, right? That delayed care that occurred during the beginning, especially the beginning part of COVID.
Yeah, significant amount of time.
It is now coming due.
It is.
Right? We're all seeing folks present. We see it in the payer data. They're sicker. They're far sicker than they've been.
They've waited too long.
Yes. So the morbidity details that we see, or the actuaries at our companies see, we're seeing it in the state level, increasing morbidity 8 to 11% higher than usual, right? We have an aging population in our state as well. That has nothing to do with COVID.
It has
That's
nothing
just
to do with COVID.
Demographics of our state. When you have an aging population, that means higher cost of care. That means more utilization of care. So all of these things are combining right now. It's almost this perfect storm that we're encountering, unfortunately.
Right.
Certainly the rest of the nation is feeling it as well. This, I call it, with the term we use is acuity, the relative risk of the population being sicker. That is not a Michigan-specific problem. That's a national problem.
Yeah, absolutely.
But our state seems to be experiencing it worse than others. Our health is worse
We're seeing that.
than others, unfortunately. And so we need good provider partners in rural areas and urban areas everywhere to be more engaged, continue to be engaged with the folks that they serve, and try to get that healthcare crisis that we're seeing, like actual healthcare outcomes need to improve in order for us to get our hands around affordability. And in the meantime, the symptom that everybody is experiencing of all of this, being sicker, being older, higher per unit cost of care, labor costs are going up, inflation is hitting everywhere, right? It's not unique to healthcare. All of these things combined are leading, as you said, to higher premiums in Michigan. In the individual market, we saw premiums this plan year, this calendar year, go up 17% in the individual market, 11% for small group, which is these are small employers, 2 employees to 50 employees, and large group went up by, I believe it was 9% on the year.
So Dominick, those double digits, 11 and 16, have you seen numbers like that in the past? No.
No, we did see a little blip that I would say was an anomaly years ago when ACA changes were being debated by Congress. There was a big, if you remember the repeal and replace mantra from years ago, there was some close action at Congress at one point to actually repealing the ACA and the tax credits and the subsidies that exist entirely within the individual market. At that point, that risk of that outcome ended up being priced in, and we saw in the individual market, I think back then was about a 14 or 15% increase, so on par with what we're experiencing today. But today really has been that perfect storm. And you mentioned it earlier as well. One component I didn't add that's specific to the individual market is those enhanced advanced premium tax credits that Congress chose not to extend.
Right.
We are very hopeful. We do a little bit of advocacy with our congressional delegation. We have other associations that our members are part of. We're hopeful they revisit this, right?
I think
this is something that, you know, the affordability theme we hope takes root nationally as well, was certainly taking root here in Michigan. And policymakers are starting to ask, what are the levers they can pull? That is a lever. That is a clear lever that could be pulled. And they did it previously, right?
They did.
So they know it works.
They did.
They know it can drive down cost. Yes, it is an investment that's needed, but I think it's the right investment to do. There are other levers that could be pulled, whether it's at the state level or others as well. But from a policy perspective, perhaps the biggest untapped policy lever to be pulled is reining in pharmaceutical costs.
Absolutely.
And I know you see it and experience it with the 340B program.
We do, which is now under attack.
Yeah, and I'll be the first to say, I'm maybe you might feel differently than me on this. I don't know that a 340B program would be needed if pharmaceutical drugs were priced reasonably.
Absolutely would not be needed.
So
100% would not be needed.
So but
there has to be a mechanism in place to protect those patients and those institutions that provide those services.
Absolutely. Yeah, you look at the pharmaceutical costs. We have a graphic that we use quite often that's a visual of $1. We say out of your premium, if that's a $1 in premium, where's that dollar being spent today? 22% of that, and growing, is being spent on outpatient pharmacy. That's going to your brick and mortar chain store, independent pharmacist store, and picking up your scripts like many Michiganders do. That's now up to 22% and growing of our premium dollars now spent on that.
Go into it.
10 years ago, that was under 20%. 20 years ago, that was under 15%. It's not because the other parts of the pie are cheaper now, right? I mean, inpatient, outpatient, those costs go up too.
Yeah, it's going up.
But it just shows how much faster pharmacy costs are going up. And again, that doesn't even account for the pharmacy costs that you experience at your hospital for administered drugs in the hospital setting. So
if our listeners listening today and says to themselves, when are my premiums going down? It's not looking very promising, though, is it? With all of these challenges, with the repeal of these provider taxes, you're looking at all of the significant challenges that hospitals are facing, labor costs, all the things you just described. Is there any opportunity, you think?
I think unfortunately, the path we're on right now, we're bracing for another double-digit year next year, right?
I would agree.
All the disruption that will come into effect from work requirements and displacement of coverage and all the things we talked about earlier will have a downstream effect into the commercial market as well. So for plans that are employer-sponsored, I would expect, unfortunately, to see even more cost shifting occurring as well. So, co-pays, deductibles, co-insurance going up. If they haven't gone up to their limits already. Many are at their limit. Yeah.
And what we hear is, they're at their limit, they're increasing. At the same time, unfortunately, pay equity is not. And so you're not able to give cost of living adjustments that are adequate to meet that. It's a significant problem we face, and it's not just in Michigan, it's across the country. Let's talk a little bit about what's specific to rural America, which is the higher incident rate of government payers compared to commercial payers. 70% of my payer mix is Medicaid, Medicare. That is very, very consistent with what we see across the country in rural America. Higher, incident rate of government payers. But as this payment model shifts and the state takes more and more on, and we have less and less reimbursement, what advice would you give healthcare leaders today about how to navigate some of these storms? Because we need experts like you saying, all right, we're looking at it from a plan design, looking at it from that model. But what advice would you give struggling hospitals about, is there anything to look forward to? What can we do to partner and to be good partners?
Yeah, I think one is partnership and continued partnership really in Michigan, obviously, but across the nation, partnership and advocacy message to policymakers at state level and at the federal level. Undoubtedly, that is something
Number one.
Yeah, that payers and providers have always been linked at the hip on, and I think should continue to do so. In those payer-provider specific conversations, though, it is a lot of the stuff you just mentioned, I think just needs to be discussed in a friendly manner with the payers that you're negotiating payment rates on, right? So if I'm a payer serving this region of the state in Hillsdale County and it's that time of year for contract negotiations, making sure that payer understands what your payer mix is. That if I'm negotiating a commercial payment reimbursement level with you, that I understand that your payer mix is 70, 75%, 80% mixed of government programs and the effects that you're seeing on those government program space, right? I think at times in the commercial space, plans may approach some of those provider relationships almost narrow-minded.
Very narrow-minded.
The leaders that I work with want to see the bigger picture. They just don't always see it out of hand unless their partner shares that with them, right? So I would definitely encourage that. I think I hear that around my boardroom with the healthcare CEOs that I interact with, that they don't want to see a rural access point, whether that's a hospital or an outpatient, go out of business.
It's usually lower cost points for insurance.
Yep. So that does not lead to more affordable premiums. That only exacerbates the problems that we find.
Absolutely.
So we want to work with provider partners.
Right.
And then the other thing we're kind of seeing emerge here is and need to do more of partnerships in order to facilitate this is this gradual shift towards more value-based arrangements, right? And that could be 51 flavors of what that might look like. It could really be.
It already is.
I don't have a favorite, but just
certainly needs to exist.
Yeah, but a willingness by providers in rural communities to want to engage in sharing that risk, but also sharing the gain when the services are provided and outcomes are achieved. Only through sharing data both ways. Health plans got to share data with their rural providers as well to have an honest conversation. And at least the leaders I engage with in Michigan, from the payer side, they truly want to have those conversations. And they want to bring data to the table, and they want to build trust, and they want to get to those value-based arrangements sooner rather than later. And I think that hopefully is those through outcomes that can hopefully sustain rural providers as well.
Let's talk a little bit about something in the news recently. And I'm not going to put you in too much of a position where you're going to have to be in the hot seat, but I do want you to shed some light into this situation. And we never name providers historically. We never name insurance companies, but a lot of conversation right now about folks not accepting Blue Cross Blue Shield negotiations. Let's not talk about that process, okay? Because we'll let them deal with that.
Yes.
I won't put you there.
Thank you.
But let's talk about the impact to the consumer. Because if there is no paring, help us understand this, then the consumer who has Insurance X, let's just say whatever it is, right? If that respective health system, which may be big for the region and the only provider, really, of notable tertiary centers, doesn't accept that insurance, what happens to the payer? Can you please talk a little bit about that?
Yeah, I will do my best. And I full disclosure, as I said at the beginning, Blue Cross is not a member of my association, so I'm certainly not.
We're just looking at it from the perspective of the patient.
Yes. Yep.
So they cannot use that product, correct?
They lose that. They have some disruption. So there's certain things, as you know probably better than I do with EMTALA, there's certain things like emergency room services that they have to. There is no change there, whether there's a contract or not.
Yep.
And then in this case, my understanding is this is commercial lines of business only. So the Medicaid, Medicare Advantage, and duals programs, I don't believe those are part of this dispute right now. So for those members, there should not be any network disruption, access disruption at all. But for the commercial members where there potentially could be if the two sides were to walk away from one another. And my understanding is they're still talking, and I'm hopeful they'll reach a resolution that's mutually agreeable. But I would worry about access issue from a patient perspective. If I'm seeing an outpatient service provider, maybe a specialty care provider or a primary care provider that's affiliated and part of that system, and if that person is no longer in the network for that health plan, you could still see that doctor, right? Maybe you've got an existing relationship there, and would make sense to still see them, but the costs will then be ultimately borne 100%
correct.
The health plan is still on the hook for what they would have reimbursed.
Okay.
Right. So anytime you're dealing
so
with
it's not
somebody
100.
outpatient, no.
Okay.
No. So it would be whatever that delta might be, whatever that differential
negotiated.
might be.
Okay.
Yeah.
All right.
So and then it can complicate things. And again, I don't know enough specific in this case to know exactly what would happen. But in general, at times you can see sometimes where there has been a payment dispute, network dispute. Ultimately, they're no longer in the provider's network, and the payer and provider are no longer have a contract in place. If care is being provided there, and let's say the cost of service is $100, just to make the math easy, if the plan was otherwise paying other providers $80 rather than the $100, that could be paid to the provider, or it could be paid to the individual.
To the individual.
So in some cases, the individual may find themselves facing the full $100 cost, and then needing to get
cover
reimbursed.
the difference after getting reimbursed.
And obviously, there's not a lot of healthcare costs that are only $100.
Yeah.
So when you get into more complex care, more expensive care, more services, the extent at which that capital outlay, if you will, from the patient has to occur first. Yeah. That's a problem. We don't want people racking up more medical debt. We don't. It's in nobody's best interest. Certainly not the patient's best interest to go get another credit card to pay for a service and then to wait on reimbursement for a portion of that cost. That is not sustainable for anybody. So again, I realize I'm speaking in generalities, but the specificity.
It's a question on many people's mind, though. You know, what happens if?
Yeah. Yep, and that's why I'm very hopeful that the two sides will reach a deal. And again, I have no
in your
inside
decade of
knowledge
experience or 12 years of experience, have you encountered a situation when there's not been a mutual agreement?
Not of two groups that large.
Me either.
I do see that happen.
Smaller. Yeah, we do as well. But in terms of the big, you do see it. But I mean, and I'm not here to advocate one way or the other. And your board does not take any type of negotiating strategies, correct?
No, we stay out of
that.
So you stay
out of all that.
Yes.
It's really just advocacy. But we also have to take just a moment to pause and say the insurance companies have been hit hard recently as well.
Yeah.
We do have to give them, some understanding.
I think in this case, I mean, what's been out in the public, and again, I'm not sharing anything that's not already out there publicly. I don't have knowledge of what's not out there publicly, but they have long said, and the data in their financial filings support this, that they have been running negative margins over the last several years.
We all know what that's like.
And it's not sustainable.
It's not
right?
sustainable.
I mean, we do have all health plans have standards that they need to and statute that they need to abide by on solvency requirements, right? And there are risk-based reserves that are required. These are required by law for good reason. You don't want to see a health plan go under, and certainly the Blues are not going under. I'm not saying
no. But, I get what you're saying.
But any payer can't sustain losses over and over and over, no more than any provider can sustain losses over.
So let's transition then, because this is only going to be intensified, this relationship between payers and providers as a result of what just happened under H.R. 1. And as that shift begins, who's going to make up the difference is the biggest question, right? So again, let's talk globally for the question here. As we look at provider tax cuts and reimbursement changes from the One Big Beautiful Bill, talk to us about what you see is going to be the biggest challenges impacting the relationship between payers and rule. I want to talk about rule because rule is, the heart of the matter of what we talk about on this podcast.
Yeah.
But there are going to be some significant consequences from this.
Yeah. Yeah, and I don't think I'm going to say anything that's too alarming to you or to your listeners, right? The idea that the rural transformation credits and process, not credits, but process is suddenly going to make up the difference here.
We cut $1 trillion, we give back $50 billion,
right?
Divided by every state, not proportionately,
right?
Yeah,
right. I'm hopeful.
Very little.
I'm hopeful some good things can come.
You're
from
an
that.
optimist, and God bless you. I used to be president of the Optimist Club. Isn't that hard to believe in Hillsdale County? But now I find myself going, I don't see the value added, especially when you cut out $1 trillion and you give back $50 billion.
No.
The math doesn't math.
No, exactly. There's quite a delta there.
There's
on that.
quite a delta.
Yeah. So I worry. I think that means the relationship between payer and providers naturally gets a little more rocky, right? I think both sides are fighting for their survivals, and certainly rural providers more than ever are fighting for their survival. I'm hopeful though that together we can work that advocacy message, that approach, obviously, whether it's policymakers in Lansing or other states across the nation, or our congressional leaders as well can understand that we need investments for these providers to stay open in rural America and in rural Michigan.
Yeah.
And we cannot, and the people cannot do without them. And I think activating those constituents, activating the patients is really the key, right? I hear from lawmakers at the Lansing level all the time that serve rural America. They may have a great relationship with their providers, but really they care about that member coming in, the patient coming in, and saying, hey, my provider is going to shut down if you don't adequately fund Medicaid or if you don't adequately fund this program.
Right.
So for us, our hands are being tied right now by Congress, in Michigan especially. We relied very heavily on direct payment programs. And the ability in health plans, I know hospitals are a part of this, we're willing participants to tax ourselves. It's a hospital bed tax.
Sure.
There's an insurance provider assessment that's a tax on the member months that we have. Our members gladly came to the table with policymakers years ago to create that tax to say, yes, tax us because we recognize that money is needed for Medicaid.
Right.
And it became earmarked and targeted for Medicaid. And now Congress has taken away some of our ability to do that. And unfortunately, more importantly, they've taken away our ability to find new taxes around healthcare.
That's right.
Right. So for those of us in healthcare, we've long said there could be other areas that could see a greater benefit if they paid in, right?
Correct.
An assessment, a fee, something, and wanting to have those conversations. Now, all of that, unfortunately, because of the actions of Congress, is gone. You cannot do it. I'm hopeful a future Congress will revisit that. We would love to engage with our congressional delegation in a joint manner. And I don't think that is just a rural issue, certainly, but funding for Medicaid hits harder in rural areas than it does elsewhere. So we just want our funding sources. We want to work with those that are willing to fund the program, and we want to dedicate the funding so that it doesn't get stolen to pay for other priorities. And I think that's the path forward. I know rural communities across Michigan, across the United States can lead and champion that cause.
We can.
And I appreciate what you do to tell your story. I would encourage that of everybody.
I would agree.
You got to
with
tell your story. You got to say what that access means to you.
Get out in front and be present.
Yes.
You know, and I think we're hearing a lot of discussion during the midterms about affordability, about preservation of Medicaid. And I think that's going to play a role. I hope it does in some decision making. Maybe those who have been staunch on one side or the other will have an opportunity to see the value that rural communities, entrust in Medicaid programs. It is so critically important. We hear, the unfortunate talking points of fraud, waste, and abuse. We all want fraud, waste, and abuse to go away, but that's not the faces of Medicaid. The faces of Medicaid is the pastor at a church that I know. The face of Medicaid is the nice lady that I know at Dollar General who's got 3 children, and she's a great-hearted woman who's utilizing the program for the right reasons, right? There's the challenges of redetermination, all those things that we can talk about. But I think the midterms, will bring about an understanding that Congress needs to align themselves with what the majority of the people want. And all of the independent polling done before H.R. 1 was passed, the majority of polling that was done, not on the left, not on the right, we're talking about independent polling, said 80% of the people said we do not want deep cuts to Medicaid. And it occurred, the deepest cuts in our history. Secondary issue was when you look at it, all right, who's going to fund these programs? The public said we want a priority to be on these programs. And we did not get that with H.R. 1. And that's a very bad scenario for hospitals that were already struggling now to have that revocation of those funds. And we know that going back to the state, like Michigan and other states, with limited budget, they're not going to pick that up. Or if they do, it's going to be at a fraction of what that reimbursement came in from the state level, so federal level. So it's always great, to have a perspective like yours. Elections have consequences, and decisions by Congress, men and women, have consequences as well. Hopefully they hear the message from their constituents. Notwithstanding what did 80% of the American people say that were polled, but what did the Office of Budget Management say? Historically, an independent, nonpartisan group said, this will be devastating for rural hospitals, and we're watching that unfold right now. Hospitals across the state and country who are already divesting obstetrics, psychiatric care, the 2 most needed in rural communities. So thank you for your advocacy. I am, time has escaped us. I do want to ask you one more question because I think it's important to talk about. All right, if we're going to try to drive down premiums, try to have some kind of equilibrium here in the market, we talk about value-based care, right? Insurance companies are working with providers now to create collaboratives to try to keep patients healthier. Where do you see that playing out in all of this? And I'm assuming you find value in those, and talk about maybe some of those if you could.
Yeah, absolutely. And I think we're just kind of scratching the surface, really, of what the future of value-based care holds. Certainly, there are more out there nationally that are well-versed on this than I am, but what I see in Michigan, our payers and providers engaging on are value-based, outcome-based arrangements, right? Shared risk and shared savings.
Savings, both, yeah.
But as I mentioned earlier, it's only happens when it's premised on trust and data sharing, both sides.
That's
right?
true.
And so the better both sides gets at granular data of their populations, either that they're insuring or that they're serving, sharing that data, building that trust, picking targets that are realistic, picking targets that are achievable, and compounding, right? And I think early phases of a lot of the value-based payment
I was
arrangements.
looking at that's not obtainable.
No, right.
I
it
looked
was
at
a
some
wild
of those,
target,
and then our savings was $18,000 for a lot of squeezing, to get that little bit of juice out.
Or it could be hit one year, but you
next
never
year
get it.
Never
get
the target the next year. Absolutely.
So I think those things are evolving, but I also see some of what you were alluding to, right? A more of a team-based approach as well.
Yeah.
And so. We like to see and partner with providers that are broader integrated. I'll call it horizontal integration of services, right? But the ability where that they're going to have a primary care contact, that they have specialty care as needed, and that they have emergency care sort of wrapped around that, but a holistic approach. And the more we can develop value-based payment arrangements with somebody that can serve that patient at every level, I think the better it will be for the providers, the better it will be for the payers, but more importantly, the better outcome the patient
will get. It would be for the patient. Now, do you find sitting around the table with your members that they're all implementing some form of this?
They were all moving towards this very aggressively, I would say, prior to COVID, right? And COVID threw a lot of things off.
It did.
For very many reasons. And I think they're getting
in other areas.
Yeah, and I think now they're getting back to it. The biggest hurdle I see right now is actually pharmacy, right? So as I talk about holistic care,
it is the number one
and
choke point.
Yeah,
it is.
And none of us, providers or payers, have a good handle on the pharmacy cost and the pharmacy spend. And
Not at all.
You can do everything in your world to manage that physical health of the individual, and they could hit one pharmaceutical cost that's $1 million.
Astronomical.
Right?
$2 million.
Yes.
We've had it before.
Yeah,
absolutely.
And we don't have a payment model that is set up for that. That is what kind of scares me for the future is as much progress as we'd like to have in value-based payment arrangements. I don't know that we'll ever be able to cross that Rubicon unless we can get our hand in control of pharmaceutical costs. And these drugs coming down the pipeline of FDA approval are amazing things. I certainly don't want to stop the science of what's going on in the United States and the progress that science and breakthroughs are making. But there has to be an upper bound on the limit.
There has to be.
And we track things. You mentioned margins. Our industry in Medicaid has been under 0% over the last 2 years. In commercial space nationally, we're about 2.4%. That's a national average. Pharma's national data that you can find.
Oh, you can find it,
right?
If you find it,
It's out there for those that are publicly traded. That's more about 24% margin. So to me, that becomes the target area. And if we can let that continue to grow, and I say we as in the royal we, and I mentioned our role as advocates, but certainly policymaker roles in D.C. and in Lansing, they need to get a handle on pharmaceutical costs.
They do.
It is crushing us already. It will exacerbate things, and it is stopping progress on value-based payment arrangements.
It is. In the disproportionate relationship, because rural hospitals have negative operating margins at times. And when you look at a partner of ours, supposed to be a partner, you look at pharmaceutical, and they're posting 25 to 30% margins. There's something wrong there. And that inequity is not very good. The other opportunity, we know early detection is early prevention. So having plans that support collaboratives, whether surgical collaboratives, keeping the patient out of the most expensive part of healthcare, which is the ER, right? You do that by making them healthy, incentivizing the payers incentivize the providers to get that patient in and to be, ensuring that that patient gets their wellness checks. And those things are very, very critical. And I think that is the only way right now that we're going to drive those costs down. And that has to be a relationship between payer and provider. And I think that's what you do so well, is advocate for that relationship when at times it can be very controversial, adversarial. And you, in your job, is to make sure that it's really all of these players coming together for the good of what we know for our patients.
Yeah, we all have the patients in mind. I think that is the thing that I'm reminded constantly in my board meetings. I just had a board meeting just the other day and sitting around with 9 other health plan executives. Every topic, it didn't matter what was on our agenda to be discussed, every topic came back to what is that interaction for the patient?
Yes. That's right.
And how is the patient getting the best outcome? Right. How are they getting the best service? Yeah. How are they happy at the end of the day? And we recognize the patients are not happy.
They're not happy right now.
And certainly not happy at our industry.
Right.
But I can tell you firsthand, the executives I interact with within the industry have their heart in the right place, are focused on patient outcomes, are focused on trying to do better, right?
And when we find that, when there's that alignment, we all win.
It's great, yes.
Payers win, providers win, but the patients win.
Yes.
And that's so critically important. We have exhausted our time today and have gone way beyond. But I do have one more question. We do a segment called Rural Health Recommendations. And we have, leaders from across this country that are new to healthcare, that are asking us questions like, how do I do this and how do I do that? Very tumultuous time right now in healthcare, all the challenges. And so we have a veteran like you, decades of experience. What recommendation would you give to a new leader in healthcare specifically that's challenged today? There's a lot of headwinds, a lot of challenges, payers, providers, recruitment, retention, all of these challenges. What piece of advice would you give to a new leader today about sage advice, keep your head above water? What would you give to them in today's environment?
Yeah, it is a tough environment. You said, it is a brutal environment out right there today. But I would say, I guess, it comes back to communication and it comes back to network and relationships. Yeah. I really fundamentally believe that. And it's probably because of my line of work.
You have
relies
to,
on
right?
That, right?
It's every day.
Exactly. So I feel that same way for rural healthcare leaders. What does that mean tangibly? To me, that means if you're new leader at a rural health, whether it's hospital, whether it's outpatient, doesn't matter what level of service, reach out to your payers.
That's right.
The payers do want to engage with you. They want to get to know you. They want to build that trust with you. Don't be afraid. Don't view the payers as this evil corporate,
empire,
right? They all have leaders that are based in your state. So even the national names.
And using your healthcare.
And are using your healthcare, yes.
Right?
Yeah, and they all want you to succeed too. They want you to be in business too, right?
That's right.
To serve their members.
Right.
So that would be the one thing I would say
Great
is
advice.
there's going to be adversarial conversations at times.
As
anytime
in any
there's
relationship.
A payer and provider,
as in any relationship.
Exactly. But communicating through that is the best and reaching out on the front end to want to establish that trust and establish that line of communication so that even in difficult times, you can still have that communication going on. I think that's vitally important for any leader today, especially in rural
what
communities.
We're facing.
Yeah.
Great advice. Thank you so much for joining us in the studio today. Dominick, it's been great to have you here, and I want to have you back.
I'd love to.
I'd love to maybe have a segment after the budget passes and
we'll talk about
a little bit about
downs.
some ups and downs because we have to address those, right?
Yes.
And one way or the other, whether there's victories or not victories, someone on the other side has concessions. I want to talk about that, so I'd like to get you back on maybe after we get through the budget process, if we could do that. And
I'd love to,
It's just been great to hear your perspective, quite a unique perspective from what we normally hear, representing, the plans that often get a black eye and payers who often are looked at as sometimes the bad guys. But all in it together, it works out for the good if we're laser focused on our patients and what is best for them. So a lot of great opportunities, a lot of great discussion today. Thank you for joining us.
Thank you, JJ. I appreciate it and look forward to coming back.
And you will be. And thanks to our listeners for tuning into Rural Health today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com and make sure you've subscribed so you never miss an episode. Until next time, remember, Rural Health Strong.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.